Assalamu alaikum. Welcome to Journal Club of this week. The article is titled Intraosseous Adenoid Cystic Carcinoma Mimicking Endodontic Preapical Lesion along with Orofacial Pain, a case report done by American group and published recently in Australian Endodontic Journal. Adenoid cystic carcinoma is a rare salivary gland malignancy marked by slow growth, late metastasis, and dismal prognosis. It accounts for about 1% of all head and neck malignancies. The case is a 57-year-old white male patient experienced excruciating pain both before and after previous endodontic treatment in teeth 42, 41, and 31. His medical history was unremarkable except for head trauma due to vehicle accident. In January 2022, root canal treatments were performed in teeth 41 and 31. 42 was fully necrotic, 41 and 31 showed vital tissue. However, the patient believed 32 was the source of pain, especially with cold sensitivity. The endodontist declined further treatment and referred him to the oral surgeon. In March 2022, a second endodontist evaluated the patient. He found trismus, dysphagia, and severe anterior mandibular pain radiating to both ears. There was no visible swelling or lymphadenopathy. Tooth mobility was moderate in teeth 31 and 41, but normal in teeth 32 and 42. Pain was severe on palpation in the anterior region, as well as severe pain upon percussion of tooth 32, moderate pain in teeth 41 and 42, and mild pain in tooth 31. Endo-eyes test was negative in teeth 42, 41, and 31, but tooth 32 showed lingering pain. EBT elicited inconsistent responses. Probing depth were within normal limit. A periapical radiograph revealed a poorly defined borders radiolucency between T32 and 42, and CBCT confirmed a through and through lesion. External root resorption with scalloped margins were observed at the apices of the teeth and visible sealer buff, and the root apices appeared decalcified on the CBCT images. The differential diagnoses listed by the endodontist were granuloma, abscess, cyst, odontogenic keratocyst, cementoosseous dysplasia, central giant cell granuloma, ameloblastoma, and carcinoma. The treatment options offered to the patient were extractions with biopsy, root end surgery with biopsy and grafting, or no treatment. The patient chose apicoectomy. And this is the surgical photo of the site, and we can see the sharp bone defect in the area. At 1 week, the patient reported myofascial pain and cold sensitivity in teeth 42, 31, and 32. At 1 month, intraoral swelling and poor gingival healing with the graft exposure were noted. Yellow pus drained as graft particles were removed. 2 days later, pathology confirmed carcinoma, prompting urgent referral to a cancer center. The final diagnosis was adenoid cystic carcinoma of the mandible and anterior floor of the mouth. For the histology, the tumor exhibited an elevated nuclear cytoplasmic ratio, sparse amphiphilic cytoplasm, and oval hyperchromatic nuclei, which are features of malignant neoplasm. The immunohistochemistry confirmed adenoid cystic carcinoma. The patient underwent anterior mandibulectomy and floor of the mouth resection. 1 year later, he developed right neck lymphadenopathy and lung metastasis, and biopsy confirmed metastatic adenoid cystic carcinoma. He began a clinical trial and surgery was planned, but he was lost to follow-up. In conclusion, intraosseous jaw malignancies present various clinical features, including bone pain, swelling, root resorption, tooth mobility, dysphagia, trismus, paresthesia, and referred orofacial pain. Similar symptoms can stem from temporomandibular disorder combined with tooth infection. Dentists should suspect malignancy when multiple atypical symptoms coexist.